Hi friends, my name is Dr. Karan Chaudhary and I am working in ASUTOSH Hospital as an associate orthopedic surgeon. Right now what I am going to discuss in this section would be calcaneus fracture fixation and various surgical tips and regarding the fixation as well as preoperative planning. So these were the times where probably a century back where different towels were used and a large hammer would be used to just slam back the lateral burst fracture of the wall of the calcaneum. Here are some of the devices that were used. Here is a traction pin that was used to pull down the tendoachilles, the posterior portion of the calcaneus. Here is another ST pin that was used in the tibia as a reduction maneuver, and various they were used to tighten the ST pin by that. I'm sorry. Secondly, these things were used to actually reduce back the calcaneum, and this reduction splint would be maintained for a long period of time. However, this was different other devices, various crutches and other things were used. These were not the permanent solutions to calcaneus fracture, however. Then came sextuloplasty, where various modalities, whether it was an axial or mechanism of actions, whether it was an axial loading or going posteriorly into the calcaneum, whether it was a joint depression type fracture, or whether it was an axially directed tongue type variety, or whether there was intra-articular displacement and incongruity. Later, these things were studied in cadavers where the primary fracture line, the secondary fracture line that was extending anteriorly into forming the anterolateral fragment, as well as the posterior piece. So this thing basically played an important role in actually understanding the calcaneus fracture reduction and fixation. So this is what we see on a lateral end radiograph, and it demonstrates two important angles: the tuber angle of Bowler. Here is the Bowler angle, and here is the angle of Kisan. The tuber angle of Bowler consists of a line drawn from the highest point of the anterior surface of the calcaneus and to the highest point on the posterior facet, and then the line drawn tangentially to the superior edge of the tuberosity, and then the angle is normally between 20 to 40 degrees, and a decrease in this angle indicates that the weight bearing posterior facet of the calcaneus has collapsed, and thereby shifting the body weight anteriorly. So it's so important to restore the angle of Bowler. Also, the crucial angle of Gissane is formed by two strong cortical struts that you can see here, and one along the lateral margin of the posterior facet and the other extending anterior to the beak of the calcaneus. These cortical struts form an obtuse angle and are visualized directly beneath the lateral process of talus. So therefore these two angles are very important during a calcaneus fracture fixation. This is the Broadens View, where the C-arm or probably the image intensifier radiograph is projected directly over the calcaneus aspect, when the patient is in a rotation of 10, 20, 30 and 40 degrees respectively. It can be easily compared with the Mortise Mortise view of the ankle fracture that we see on an X-ray. In the CT scan, the most important factor that we look for is the sustentaculum piece, that you can see that it is quite depressed and would be requiring elevation and fixation. So these are the various classifications that were given by different authors during before the Sanders classification was published. This is the Sanders classification that I'm going to discuss in quite a moment. This is the medial approach that we may need to take if the sustentaculum is displaced and would be requiring reduction from the medial side, it is very important to note that the neurovascular structure runs medially, and the incision that has to be taken has to be below the neurovascular bundle, probably parallel to the bundle that we can see here. So these are various modifications of approaches. The lateral approach that was been given previously, people used to follow, where there would be a curved starting just at the level of the lateral malleolus and then extending downwards towards the fifth metatarsal base. Here you can see that the incision would be extending, it would be quite at a lower surface and would be continuing in a zigzag fashion up to the fifth metatarsal. So you can see how in both these approaches and how we can approach the calcaneus fracture fragments. We basically see for a wrinkling sign over the lateral aspect where the incision has to be made, and if this wrinkling sign is positive, then we are good to go for surgery. Many orthopedic surgeons have a difficulty understanding the classification of calcaneus fractures and how it is exactly classified. So right now I'm going to explain you with the help of this bone model that I am running right now from my iPad and mirroring it into my MacBook Pro. This skeleton premium visible body application that is available over my iPad, and this is a model of the ankle joint. This is the talus, this is the calcaneus, and we are looking at the lateral aspect of this calcaneus bone. So I would take my time and go slowly so that every one of you understand exactly how this calcaneus classification and the fracture fragments are being taken into consideration while we look at a CT scan, and then how we plan our treatment. So basically exexloplasty started seeing these lesions over the calcaneus bone, and he believed that the primary fracture line would be formed laterally. So it would just begin here, and the lateral process of the talus, this lateral process of the talus would have a impaction and produce, and then it would just hit the calcaneus, and then the fracture line would be extending medially. So he believed at the time of impaction the subtalar joint, so basically the subtalar joint would be forced into eversion, so it would just come outside and would divide the lateral wall and the body of the calcaneus at the crucial angle of Gisane. So it would be just divided up here, right, by the impaction of the lateral process of the talus, and the remaining force after the formation of the primary fracture line would be dissipated medially into the sustentaculum tali. And so with the continuation of the force, the fracture line could exit through either the anterior process or the calcaneocuboid joint here. Right now I have removed the cuboid joint for purpose of visualization of the calcaneus. So the anterior portion, the fracture would have been extending into the calcaneocuboid joint, and that would result into an anterolateral fragment, and the secondary fracture line that was created with an increased force, and if the force was directed posteriorly, the fracture would continue both posteriorly into the posterior facet, and thereby producing a joint depression type fracture. And if the force would be directed axially, so if it would have been directed in this manner, a tongue type fracture would be produced, keeping the entire piece intact as one. So later this thing was experimentally created, and the intra-articular calcaneus fracture in a cadaveric a cadaver was isolated. So basically two fracture lines were identified. One line divided the calcaneus. So now what I'm going to explain you is after disappearing the talus. So I'm going to hide this, and now we are going to see from above. We can see this aspect of the calcaneus, the medial aspect, the sustentaculum, and the anterior process. So Now, so this is the primary fracture line, and this would have been the secondary fracture line extending into the posterior facet. And so it would be dividing the calcaneus into a medial portion, a lateral portion, and then the primary fracture line would be dividing again into an anterior portion, into a posterior portion. Uh, so this second fracture line continued medially to divide the medial facet and probably towards the plantar surface or there anteriorly. And these two fracture lines produced a combination of fractures, including both probably a tongue type or a joint depression type fracture. So later, right now, what we understand by the classification, what we take into consideration is the Sanders type classification. So in the Sanders classification, what we see is based on the coronal images. So we see this image, we would just shift it a bit up, and so we see this portion. What we can see is this cross section, and what we take into consideration is the broadest part of the talus. The calcaneum just below it is responsible, probably because of the weight bearing axis of the talus and the fragmentation that actually takes place. So basically the coronal images, ideally all the coronal images should be taken into consideration, but usually the widest portion just beneath the talus is actually taken. And then the talus is divided into three columns, like this is the lateral side, this is the central side, this is the medial side, and this is the sustentaculum tali. And this forms a baseline over which the entire calcaneus is planned to be reconstructed. And so these are four potential articular pieces, and if it is a non-displaced articular, in spite of how many ever fragments this thing contains, we still take it as a type 1 fracture because it is undisplaced. And then depending upon whether it is a two-part fracture of the posterior facet or whether it is subdivided into A, B or C based on the location of the primary fracture line. And type 3 has 3-part and has a central depressed fragment. So what we can see here in a type 3 is a centrally depressed fragment. And then again the 3 is divided into a AB, AC and a BC. Probably it is the secondary fracture lines that arise from the basic line, and then what we divide it into 3 parts, like this is the medial portion, so the lateral portion we label it as A, this central portion is B, and the third portion that we can see medially is C. So on that basis, 3AB or 3AC or 3BC, depending on which of the columns of the calcaneus are involved. Type 4 are the 4-part, highly comminuted and have more than 4 articular pieces, while the subclassification of articular fracture lines are from medial. This video covers the various anatomical aspects of the calcaneus fracture. Now in the next section we would be understanding the various surgical aspects of the calcaneum. If you found this video useful to your knowledge, please do leave a like, or if you have any doubt, please leave a comment, or do subscribe to our channel for more of such videos. Thank you.